How's it going? Good to see you. Just prepping some codes, as always. Hey Terry, how's it going? Hey Mags, or me giggles. Hey Jen, hey Twinkle, how's it going? I think I got that one done. I have been highlighter happy just like you. Yep, it is the best thing to do, especially when it's in the CPT code descriptor. Whatever is in these parentheses, that is what I'm seeing more and more in those questions from the exam, especially if it's a looky, one of those name brand names, just like that. They love it. I like to know whether I'm plural or singular. I like the push button highlighters. No real preference on which ones they are. Just make sure you don't get one that's soppy wet because we put so much on. The line, sometimes when you do a long line, if it's super wet, it'll wrinkle the page right there. So you just have to make sure they're a little dry, not too wet. How's everybody doing? I know y'all been waiting like crazy for me to get on today. Today was a crazy day. Started out great on time, 7 a.m., had tutoring going already, went and got the kids up in between them practicing questions without me, got the kids up, got them going, made sure their teeth were brushed, back to tutoring, and Travis comes to me about an hour later saying, in tears, I can't get a ring off, so I have to end my tutoring really quickly because, of course, I slap on some lotion and it ain't coming off. There's just no way it's coming off. Nope. He apparently put it on last night, went to sleep with it, got up this morning with it 10 times bigger than what it was supposed to be. Didn't say anything for the first hour, waited till it was time to go to the school bus and told me. And so off to the fire department we go, because I know they got a ring cutter, right? You know, that should be simple. We still got an hour before school starts because I get him up at 7. He has to meet the bus at 8:15 because school starts at 9 a.m. here. So we still had an hour. It was 8 o'clock. I figured right around the corner is the fire department. We can go over there and get that sucker cut off real quick. Well, we go through every blade they have in the fire department, and they can't get that ring off. And the ring is not able to be cut through, so they send us to the emergency room. Of course, we have to go into the emergency room. We get there, and they try their blades. And they got one of those Roto-Rooter Dremel machines, you know, so they put on the diamond blade and go after it with a lot of noise. And of course, Travis's ring choice decides to eat through all their blades too and is unable to even make a dent in it at all. So we call another fire department and have those guys bring over their blades. And we go through their blades too. By now, his finger is way worse than what it was when I even brought him into the fire department to begin with. Because everybody's been meddling with it and messing with it. And he's not in tears, but he's thinking about it. And plus, the ring is getting super hot, temperature-wise, as they're cutting on it. And he'll stop him every so often. Wait, 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 wait. It's hot. It's hot. It's hot. It feels like his finger's burning underneath it. So we call up to the surgery center to see if they got any surgical tools that are good for cutting rings off. And they don't seem to know if they could get anything on that hand that could cut it. So the maintenance guy comes around with his bolt cutters, and Travis takes one look at that and bursts into tears. And yeah, we decide, well, okay, let's do a nerve block on this hand and just pull the dang thing off. So he ends up getting a nerve block on his hand. And then we have the fire department, who's still there in the ER with us, manhandle his hand down so that he can't pull backwards. And then I wrap my legs around his legs so he can't kick the doctors. And we go at it, pulling at that ring and shoving his now swollen skin up underneath that ring and pull and pull and pull. And we finally get that thing off. But oh my gosh, we went through the city's entire supply of diamond cut ring removing whatever blades they are. I hope nobody in town needs a ring cut off, because Travis's ring, it was part of a necklace, like one of those $2 Chinese necklaces that has a ring on it that's meant to be worn around your neck. It's not meant for your finger. You only put soft metals on your fingers because your fingers are always getting in somewhere, and if it gets hurt or crushed or injured, you need to be able to get that ring off very quickly. And that's why gold and other softer metallics are used on fingers. Well, Travis, I don't know what this $2 ring was made out of, but my goodness, it just laughed at us all morning long. He insisted as soon as the ring came off that he had to go to school. So he went to school with a nerve block in his hand. And this is the offending ring. It's that music band. Who is that? BTS, whoever the heck this is, but it was a necklace. So he took this off and put it on as a ring. And that's the dents that the two fire departments made in it. That's all they were able to do. So yeah, we had a fun day starting out anyway. Bless. Yep. Anyway, that was fun. Fun day. So I had to end tutoring. I've got people that I was in the middle of tutoring with and had to just go. So I've got them rescheduled, I guess, for tomorrow and Friday and Sunday. So that threw my whole day off and why I'm late today. But I have some really, really, really cool questions for y'all today, even a new immunization one. So that's going to be fun. Hard metal is brittle. Tap it with a hammer and it will shatter. It depends. I don't know. That thing must have been made out of I don't know what, but it's super, super thick and crazy. It's not like it's, you know, I have like other rings that he usually wears, like his new, I got him a new fidget one that has these beads in it you can fidget, but these are meant for rings because they're small, bendable metal. But this sucker is thick as it could be, just as thick. And they went at it with drills and they could not get anywhere with that thing. I don't know, it's super, super thick. I mean, a lot different metal than whatever this is. Yeah. Anyway, no more rings. No more rings, Mr. Travis. No more. No more boy band stuff. No. I'm done with that. Stretches like taffy. How would you code that? Y'all tell me. Hey, Trisha. Yeah, I had to call the school too this morning, and the receptionist was like, "Oh, I have a ring cutter here at my desk." And I'm like, if the fire department's ring cutter will not get it, I'm sure yours that you have at the front desk won't work either. I'm going to take their advice and go on. But that's good to know that the office has issues with rings getting stuck on kids' fingers, that they actually have a ring cutter at the front desk. So that's cool. You're taking your CCS tomorrow? We'll be thinking good thoughts of you. I hope for the best. I've got several that are taking it this weekend too. Miss Edwards is going to be taking hers on Saturday. I hope everybody, she is the juicer lady who's got me juicing. So everybody please think good thoughts of her. She's been tutoring with me twice a week for several months. I'm sitting here drinking my juice right now. I've got black cherries because I love those things. Those mini oranges, whatever the heck, those tangerines. Yep. Black cherries, tangerines, cucumber. And an apple in there. It's so good. So good. She's testing this weekend, and she has to travel far and do a hotel. I think several others are too. It's still my birthday month. You know, you guys cannot not pass on my birthday month. Does anybody know how Maya did? Didn't she take hers online a few days ago? I gotta check back with her and see how she's doing. I did talk to Betty in case everybody's worried about her. Her kiddos are sick with sore throats. She's fine. Everybody's fine. She'll be back. She's just busy, busy, busy. I was like ready to stalk her down and see if she's okay. But she is fine. Nothing to worry about there. As I divulge her HIPAA information. But anyway, hopefully she won't sue me over that. She will be okay. She will be back. And Travis can sue me all he wants. I'm going to tell y'all all his stories. Yeah, I know. Everybody's been worried. Best wishes. Best wishes. Hey, there she is. We are thinking about our juice lady. She is here. Oh, did you see my juice I was drinking? Yep. I'm drinking away, and I'm still blending it. I know. My son does the juice. He uses the juicer, but I like blending it. I like the thicker consistency, but he likes the juice, so he'll make some more tonight. Well, since she is here, she was working. She was one of the ones that I was working with this morning that I had to stop tutoring and go run off with Travis to the adventure. She has seen some of these questions. I'm going to move to the bottom down here and get to the ones that she has not seen, because we did a few of them this morning. And then I'll go back up to those. All right, where are we at? We did that one. We did that one. We did that one. That was a good one. She was so sick of these anatomy ones. Oh my. I kept hitting her with the anatomy. Okay, we did that one. I think that's one we were on. I don't know if we did that one. What's the next one? We did. Okay. So I'm going to do this one. I'm not sure if we were on it. I think we were on it. But the next one is the vaccine one. So here's a new anatomy one. if I can get my thing to concentrate on my... Come on. You can focus. I know you can, camera. I did another live today on YouTube, and I did some book prep on musculoskeletal, but my camera is fully charged, so it should not be too angry at me. It should focus. There we go. All right. So if Betty is around, this is a good one for our abbreviations, by the way. Typhoon, you passed. Yay. I'm not sure if I said that name right, but that is so cool. You did pass because of the videos. Awesome. I'm so proud of you. Thank goodness you passed. Never have to take that test again. Keep your CEUs paid and your or done, and then your annual fees done, and you never have to take that stupid exam again. That's wonderful, wonderful. If you need any help afterwards, our Discord group does have CEU help, job help, and extra certifications if you want to go in and go get your risks done. If you want to go get another certification, we got a practice room in there for those questions too. And the CCS people, I posted 2 questions in there last night. I need to update the answers, but I put in y'all's room 2 new questions yesterday on the Discord. Yep. It's very fun. There are links in the bio here on TikTok, but I do have lots of rooms there on our Discord. So we do have job help and CEU help, and then the CCS people, I posted new questions in y'all's practice room too. So anyway, anybody know what EOE stands for? And what would cause this to be exasperated? Jill's got D as her answer. Anybody else? Anybody know what EOE is? This is the last one that Miss Edwards and I worked on. Yep, we're going to have, it's eosinophils. It does start with an E, so that's kind of a hint right there. So that's really nice. It's the stricture of the esophagus, so it's a long-term condition. Usually happens in the elderly where they can't swallow very well, clear their throat, that kind of stuff. So eosinophils can make it worse, absolutely. And there's your answer and your rationale to go along with that question. Now to immunizations. There you go, perfectly. Very good. Nice spelling of all that. So in the back of our book, in the back cover of our CPT book, we have a list of abbreviations. That one is not there. So you should write that in, that EOE equals how perfectly just spelled it. Exactly like that. Write those 2 words there. Don't know how to pronounce them, but y'all have at it. I'm sure it's simpler than what I'm trying to make it out to be, but as long as we know what the definition is and can pick it out, that's super helpful. So our new immunization, we are not given a choice about the vaccines or to code those or the office visit, but what we are given is just the administration answers. So you need to know how many components are in your MMR, how many are in the name brand Pinktonel, and then how many components are in your flu vaccine. And then you need to be able to pick out the correct answer. The patient did have extensive counseling, It's our only option, so we do have the 60 throughout, which is fine. How many components are in MMR? Does anybody know? And if you don't know, I have a document in our Discord group that lists the vaccines and lists how many components are in it. So you can go to each CPT code and write the components down. Very good. Mumps, measles, rubella has 3 components. Good. How many components are in the flu vaccine? Influenza. Sure, let's finish this immunization one, JP, and we'll do your E&M. Good, Sandy. Flu vaccine has 1 component. How many components does this pentanel? It's a tetanus shot. How many does it have? How many components? To know that, you'd have to know the CPT code that's related with it, right? Which is in the front of your medicine section. And it is CPT code 90698, I believe. 90698. If you don't have that name brand written down beside that CPT code also to help you out, be sure and write that in during this time. It's not one I like to give. I liked the Pediarex better to give. This one was a newer one. I like them to be out for a while before I give them. So I never learned its proper name. Correct, y'all, it's 5. So knowing that, we add those numbers up and we'll get the number 9. Which one of these answers equals 9? This would equal 4, right? 3 plus 6 equals 9. This one would equal 12, and this one would equal 3. So knowing how many components will definitely help you out. You just need to add them, and then you get your answer, which is B. Yep. And then we got our rationale. Breast cancer. If somebody is currently has ongoing chemotherapy and reports dehydration due to continuous nausea and vomiting, she's given pre-packed solution of 1,000 cc's of saline, and her infusion started at 9:05 and ended at 10:20. How would you code that? No worries, JP. I forgot. Got to remind me. No, you can post your question whenever you get a chance, and I'll stop and we'll do your question. Is it cannot be reported, or would we use one of these codes for the infusion? I have an A from mean. No, you probably can't screenshot it and send it on TikTok. You probably have to type it out in chat. A little at a time. Hey, Twinkle. How's it going? A is our answer. Perfect. Perfect job, you guys, for that one. We do have our hour and 15 minutes, which is just our 60. If we hit 1 hour and 30 minutes, then we could do our B. But for right now, A is our answer, even though I'm scratching it out, being weird. All right. I don't have these organized like I normally do tonight, but that's okay. It's been crazy. We've got a jawline. We got metastatic. We have incisions. When I look at this, and if I didn't even know what the answers were at a time, I know these are tiny. These aren't even 1 centimeter. These are itty bitty. So if I'm thinking about CPT codes, whatever range they're in, it's going to be a smaller number numerically because of our sizes, right? Our sizes are tiny. Just keep that kind of stuff in mind as you're perusing these questions before you get to the CPT codes, because that can help you knowing whether you're going to be mega big number or you're going to be a tiny number. That kind of stuff can help out. We did have a suspicious lesion, unknown. Malignancy is a real concern, but we don't have a malignancy diagnosis, right? That's all we have. So if we don't have a malignancy diagnosis, we probably could get rid of that C code, right? A right off the bat. And then when we get to that one off the table, the process of elimination can kick in, yep, and we can get rid of that one, and we have our two numbers here, but then this number is smaller than this number, and our sizes are super tiny. We used a big suture number, but that's just there to confuse you. That's just the stitching line. That's not helpful. But those two being smaller, I would pick the 2 smaller numbers for sure. So let's see. Total time counseling. She has knee pain and had her replacement 6 months ago. And the patient is concerned about thrombus infection, 25 minutes. Total time counseling on her symptoms would be if she had an infection or thrombosis. And answering the question, she was reassured of pain and overuse conditions and was instructed to ice her knee twice a day and avoid stairs. She had it 6 months ago. How much time was spent examining the patient? I wonder. We've got her counseling was 25 minutes. Well, what's your options for your answers? Because I've got 25 minutes was her counseling, right? Am I reading that right, guys? No other muscle pain. The patient was concerned about thrombosis. 25 minutes. Total time was spent, in counseling the patient about her symptoms. How much time did he spend examining her? It just seems like that says total time counseling, but you still have to do your examination of your patient. No mention of examination time. What's your options for answers? What do they want us to choose from? Because clearly the example isn't clinically appropriate like you would code it in real life. You'd need to know the total time seeing the patient, but what are our options for answers? Or is this one you just have to code on your own? She's established patient, so you know she's going to be under the established. And if you only go 25 minutes, she's a 213, right? Yeah, I agree with Mean, 213. Thank you for the share. That's awesome. So my thought process is that she's new or established is my first thing. You said something about her being 6 months ago, and that the only thing we don't have an examination, we don't have a history, we don't have her MDM. So no worries. I think that a 213 is all we can do because it's between 25 minutes. And if you look underneath those CPT codes under established, what we have to code is the MDM, which we don't have, or time. And those are the two things that we use to code between the 99202s and the 99215s. All of those codes in between can be coded with just an MDM or with just time. No reason to be sorry. I hope it's helpful that we got you the answer. If you've got any more, let me know. All you got to do is type them out and get to it. But C is our answer, and we do have some rationale that's just foolishness, but yes. Well, how I would attack it during the CPC exam is exactly how I did, is just go through there and look for your coding irregularities, do your process of elimination, and then think clearly, am I looking at something that's super big and nasty or something that's little bitty? Also, this is non-malignant. This is malignant. If you know a little bit about your codes, the 14s are non-malignant, the 16s are malignant. That too can help you, but also just thinking about the sizes help me there to get to the right answer is C. Here's our next one. Let's try this backwards. So we have a difference between our 16s and our 14. We have the same answer down twice, and the only difference is can we add that code or not? Thank you, Go-Kart. So that's cool. What is our 11643? Where are we at? 11643. Removing lesions. We got sizes, no parentheticals, nothing about using or not using that 1200. Need to see if we're doing two different procedures, but what are we supposed to have with these if we're doing multiple procedures? Yep, we got basal cell, squamous cell, or melanoma if we're doing our 16s. That one's non-malignant. So we do see our squamous cell, right, of the cheek. We remove whatever, and then we do an additional for our margins, and then we do a closure. Do you think we did two things? Yeah, I think they're just trying to confuse you. But we would probably need modifiers with these things to go along with it. We do have B as our answer. Very good. And you got rationale. Lots of it. I find it unhelpful. I think looking for the coding irregularities and then knowing whether you're in cancer or not in cancer and what the labels of those cancers are is helpful too. Anything from the 116, the 11600 area is all types I have listed as basal cell, squamous cell, and melanoma until I get down to my 11719 and we start doing fingernail and toenail removals and stuff. Let's see. What have we got going on here? We've got, if I was, betting, I like the specificity of having 6 numbers instead of just 4 or 5. And could we use Z as a first diagnosis? We do have some that can be first diagnosis, so it's either B or D to me. That's just me looking at it and how I would rationale it out. We can look at our question. We got a post-op follow-up. We got stroke. There's a guideline tied with stroke. Was released and he's here for a follow-up. How would we code? Yep, we don't use any stroke codes unless they're having a stroke in front of you. TIAs are the same thing. They have to be literally having that in front of you for you to be able to code it. The rest of the time, it will always be history of. And that's why they're being seen. So B is your answer. Does that make any sense? And I would go even to your I-69 codes and put a caution. Unless the patient is having a stroke in front of you, don't code this. Go to Z86. That way it's there for your exam. And in turn, go right here, go to the Z86s and put down history of being seen for a follow-up. Great. If currently having a stroke in front of you, go to I-69. That way you have it in both places in your diagnosis book, and then they can't trick you on the exam. We do have B, and we got tons of rationale. That's just foolishness. Lots of crazy stuff to look at, but we do not code TIAs. One of the most misused diagnoses in the world, and besides our modifier 59 in the real world of coding. And if you code a patient with a TIA in your office and you send that out on a claim, I guarantee you Medicare will be in auditing your office because you did that in real life. So do not code TIA in your office unless you are 100% sure that patient had a stroke in your office. Y'all called an ambulance and got rid of them or something. Whatever had to happen, but something. You probably wouldn't even code that visit because they ended up going to the OR, or to the ER. But anyway, don't code that in the office. Just so you know, you don't want any audits. You get the more money for coding that particular one for having to intake them and take care of them. So that's why Medicare would come in and fuss at you. All right, social determination. Which documentation may be used to report social, or who can, what kind of person can, or group can, code the new 2022 guidelines for social determinations. These are like for if the patient is homelessness or has food insecurities, things like that. Who can code these? And what is AAPC's favorite answer? To give you some hints. Did I lose everybody with TIA? I know it's getting late, huh? 7:30. So it's 10:30 probably in Florida. So sorry it's so late. Yes, all of the above. All of the above. Yep, any of the above. Anybody can document those, including medical assistants in the office. Which one of these conditions is a social determination of health? Good job, Halo. Elise. Terry. Dirty Red. She was in on my live today on YouTube too. Good job. You did it right. Very good. Lack of transportation is a social determination, not a personal, like your personal illness. This is just your social life. You have no car. You can't get to the doctor. That's one of the risk factors for that. Yep. She's probably had to change her name on all of her social medias just so that when I see her, I see Dirty Red. All right. We got tons of modifiers here. That's probably going to be our easiest way to figure out what the answer is. We either have no modifier or 58 is staged, right? 76 is repeat. If you're not writing on your test exam booklet or on your white erase board, this kind of information during your exam, you're going to drive yourself nuts with your fingers all in the book, holding on to CPT codes and going back and forth, and then get yourself all confused and pick the wrong answer. So please be sure and write down a little something to keep you straight. We know staged. We know repeat. I don't know why I'm doing a P. And an unplanned for this one. So a surgeon is going back into the ER to remove a lumpectomy cavity where the pathologist says the margins are not clear. How would we code this? You're saying a repeat? Hey, Dawn. How's it going? Glad to help. Hey, Mother Hustler. I was hustling this morning, trying to get those fire department guys to cut off that ring. They just could not. Ooh, we got a gamut of information. I mean, just a ton of different answers. Hey, Al. Aw, thank you. Take your test in May. You have no clue of what you're doing. Well, Sarah, hang out here. I'll put a little bit of clarity in it for you. If you haven't yet, go look at my YouTube and just watch those videos too. Those will help you. I know I talk too much about my kids and everything else and stories of the healthcare system because I've been in it for 20 years, but if you can overlook some of that, my videos are really helpful. Plus, so are the, I teach for free, so all of it's for free. I have a Discord group with tons of practice questions in it and helpful people there to help you out too. There's a link tree in my bio here with all that info. I just charge for Sunday workshops when I do them once or twice a month. That's it. And it's just $10. Other than that, all my teaching is just free. So I'm here Monday, Wednesdays, and Fridays doing a couple of hours of teaching you to how to take the exam so that you can pass your certification and get a job. You've got a lifelong time of learning coding because it's going to change from day to day to day to day to day to day. It's even going to be different from one office to another office, how you code. So you'll learn that on the job, but you need to pass the exam to be able to get a job in this field. So that's what I'm here to do. So I am here to help you. You're not doing great. Keep at it. Keep at it, Mother Hustler. Just keep at those practice exams. You can even do them 1 or 2 questions at a time. Hit grade. Look at your rationale. Go look at those answers. Find out why they are the wrong answers. What does make a difference between those codes? Why would they be asking it? And why the right answer is the right answer. And I don't know if anyone got this one right. Let me look through my answers. Oh, one person got them right. Got this one right. You're a CMA and AAMA, and I can't get coding. Been through the class since September. Yeah, some people, it's rough. Coding classes teach at you. They throw data at you. What I do is explain for you. I don't know. Does that make sense? Like, I'm not teaching at you. I'm a little fast tonight, but I explain it for you so that it makes sense. Make it you can associate it with real life things so that you can understand it. Hey, Bluebird. I've talked to you before. I love the Bluebird movie with Shirley Temple in it. I love that one. Mean got it. You know she did. She's awesome. Some of the practice stuff I create, some of that I find off of my CEU training. Some of it I pay for. Some of it I make on my own. It's just all over the place. Gamut of all kinds of places. I have a franchise contract with AMA, so that gets me access to be able to share things too. So it's a lot. It's a lot goes behind the scenes to get this stuff out. You really want to take the exam again? Go for it, Chrissy. You can do it. I can show you how. I can show anybody how to pass the exam. You just got to follow my steps one at a time. Do one code at a time. Go look up what the differences are. Then only search the question just for that difference and pick out your answer for sure. Yep, learning the lingo with the medical terms for sure. But I don't know how to start. I have a TikTok here that is labeled, "Where do I start?" That TikTok is the perfect place to start, for sure. You can take the exam as many times as you want. I've helped people who have taken it 10 times before they met me. One lady took it 9 times before she met me, never put a drop of notes in her book. Then she met me and figured out what I do in my CPT books and learned that you could write in your book and take notes. And yeah, that's fun. You can take it as many times as you want, and you can pay for it as often as you would like. I like AAPC because you do get 2 tries with each payment if you take it in person. So that's handy dandy. You've taken it 3 times already, Chrissy. I gotcha. That is about the norm before somebody passes. Usually the 3rd time is when somebody passes. So not everybody, you know, but that's the above average one right there. You're taking yours on this Saturday? Oh boy. I even have a document too that about what's been on the exam the last 45 days that could be helpful too with the vocabulary and stuff. She does. According to, she has been tutoring one-on-one with me for months. Yep. We do it every morning. We're supposed to do it every morning this week, except for Tuesday morning. So we had Monday, Wednesday, Thursday, and Friday scheduled because her exam's on Saturday, and I flaked on her this morning. Where is the vocabulary doc at? It is on Etsy if you want it. The girls that have passed the exam or taken their exam have put the ideas and shared the information for us to put it there. That way I can give out free tutoring and notes to people that are in need. So it is on Etsy if you want it. It's like $20, somewhere around there. Anyway, let's figure out the answer to this question. And mean was the only one to get it right. It is the 58, which was staged. So if you go in and you don't cut enough of the cancer away and you got to go back in and cut more of it again away, that is called staged without telling you it's staged. So remember this example. Go to 19301. It's a re-excise. Use that terminology next to that CPT code. If you have to re-excise because your margins are positive, then it is a modifier 58. Be sure you know that for your exam. There's a link tree in this bio here in TikTok that'll lead you to everything I have. It's on my website, what's in our Discord. That is super fun and free and so helpful. I know the re-excise, yep. It's like it's an essay exam, you know, like when you're writing an essay for college and you're just trying to fill in some words so that you can meet your number count for what it is. They're not trying to say the word staged by saying a bunch of filler words that mean staged, and you wouldn't know it if you hadn't seen that question before. So don't feel bad, Tammy. I'd rather you not get it. You learn best by making mistakes, getting things wrong. Once you figure out that it's wrong, you won't forget it again because you got it right. Yep. So that one is there, and there's your rationale for that one. So crazy. Staged or related procedure. So staged doesn't always just mean staged. When we look at that CPT code descriptor in the front of our book, we're only seeing it. If you're looking at the front cover and not going to Appendix A, you're only seeing just a tiny description of it. So it may not have, does it? It does have related services there. It does. It has the full description. Oh well. We're just not paying attention enough. We think staged moved on, but it does say related service. So, muy important to pay attention to. Underline that on your cheat sheet on the front cover that it could be related. Here's some more codes. We are still in these non-cancerous, cancerous, or if we're in the musculoskeletal section, we're dealing with masses and lipomas. And that's a lot to know. And it took me a long time to know, and a long time tutoring people one-on-one and on these Monday, Wednesdays, and Fridays to get around knowing that kind of information in my head. But what you should do during your CPT exam is go to that 1400. What is that? That is a benign lesion removal. And you should write something beside your exam or on your dry erase board, benign. Then we have malignant. Then you should go to your 213 and you should write lipoma or mass. I have two M's, but lipoma or mass or none of these. You should know this kind of stuff. If you don't know it in your head, like I do, go to those CPT codes. Write a little something about them. Now, all we're going to do is we're not going to read the words of the question. We're just going to skim the question for what is this object that we're doing. Are we dealing with a benign malignancy or a lipoma, something like that? What would this one be? What do you guys think? Yeah, Dawn, it's very difficult to understand the different meanings in lesions, masses, lipomas. It's rough. I'm working on it myself. Sorry, I guess I shouldn't cover up the answers, but where would we start coding? And it does not happen to be their favorite answer this time, unfortunately, just so I can let you know. Where would a subfacial, whatever, deep lesion be? Where would that be? Is that under benign, malignancy, or lipoma? Shelby, you got to bet on Mean. She knows it all. She's good. We've got our musculoskeletal. So, those words, subfascia lesion deep, right above, like even on page 104, and then where we're doing our excisions of lesions on page 102, if you're in the 2022 book. At the very top, above all the headers where the page numbers are, or the date, CPT 2022, right up there at the very top, write subfacial lesion deep equals musculoskeletal. Go to 213-40 to this one. And in turn, that will help you if you write it above those two pages, and don't forget to look at it during your exam. When you see that wording, sub F, whatever that word is, will help you not pick the wrong answer and go straight to the musculoskeletal section. Say it again. So, because this is a lesion removal, right? I would go to my excision of lesions in my integumentary system right here. I'm on page 102. And somewhere on this page, I already have a list of what constitutes a benign lesion on this page because we got it from those guidelines over here in our guidelines. That list right there that I yellow highlighted, we moved it to the codes. Remember one day during one of our lives? It's hard because it tells you what lesions go underneath here in the guidelines on another page. So we moved them all here. We put benign neoplasms equals this CIC thing, fibrous inflammatory, congenital cystic lesions. That was the list from over here. Now, what I would also do, because of this question, I would take that subfossa lesion up at the top and write it right there and say that equals those codes, so that I wouldn't code something that's subfascia here. I would go to musculoskeletal. Would also do the same thing over here on our malignancy list. We have a malignancy. We have a list of what those are. We moved it to the codes because they're on a separate page right here, where all these are the malignancy lesions. We put that list right here, basal cell, squamous cell, melanoma. Well, I would, again, at the top of the page, write subfossa up here somewhere, and then say, when we're doing that, we're going to be going to those 213 codes. That way it's just listed here in integumentary where lesion removals are. Those are the 2 pages. That way you have it to alert you that you're going to be in the wrong spot if you're coding these. These need to be coded over in musculoskeletal, unless you can remember. Does that help? Go kart. What I was trying to say. I'm just writing a little note here on my cancer ones, my malignancies, that the subfossa whatever needs to go to musculoskeletal. So you guys have the notes next time I put a new version or something up. But for right now, I know it in my head, and I forget things that I know in my head that you guys might not know until I see questions like this. All right. Yes, I can show you again what I wrote. So on the 1600s, those are the malignancy ones. I have my list of what is malignant right here on this eye picture, and then we start coding the malignancy ones. I also put in red sub whatever goes to those codes. Now on the benign lesions, where I already had the list, which is the 1400 codes, they start right here. At the top of its page, I put subfos equals go there. Just so I have it in eye shot of my list of what the names are for those. And you don't have to purchase. I'm happy to show you how to do your own notes and make them that way. You can go to my website at medicalcodingbyjen.com, go to the CPT book prep page, and it shows you how I prepped my book pages and how you can do the same thing to your books. Or if you're in a time crunch, and yes, you do need the pages page by page right away, you can go to Etsy and they're all there, so you can just print them out or save them on your device and then write them in as you can. Depends on what time frame you got, but whatever. Happy to do whatever. You're welcome. Thanks, Terry, for the shout out too. But happy to help you guys. Y'all got a lot of money in it already, especially if you bought a course. Oh my gosh, those courses are so unhelpful to help you pass the exam. They'll teach you how to code, but that's not how you need to get through this exam. Not one bit. And there's your rationale and your answer for this one. Let's see. All right. Let's see. We got a wordy question. Everybody loves these. How can those serving as external consultants provide guidance to, my pages are turning, to clients regarding code selection, claim preparation, denial management, and payment, mitigate false claims and liabilities? Woo, Lord, what a question. So, are we going to act as a decision maker? That probably doesn't make any sense. I just like looking for keywords. Advise, develop policies, or interpret crap. Ooh, that's scary. What do you think? What do you think? Look at that question again. How would we advise external people handling our claims? Not sure. Denial management, your team management. I know. Based on your expertise, or you have researched payer-specific reimbursement policies. Yeah, yuck question, right? Definitely wouldn't act as a decision maker. Local determination, LOC, means they do the interpretation. We don't do no interpretations. We can develop policies or provide advice. Did Mean give an opinion on this one? She gave B. B is true. We do have to look up payer specific, which is a nightmare. A lot of times you'll have a rep with your insurance company that you're dealing with, and if you're getting denials on your claims, you'll call your Cigna rep and say, okay, what's your policy on this CPT code? Blah, blah, blah. And they'll give you that policy. And then it also you need to think about things like, well, if you're billing that CPT code with an E&M code, you'll need to have both policies for that E&M code and that CPT code, and see if they don't interact and also cause you to have some denials. Modifier guidelines also, there's quite a bit. So when you call your rep and ask them about a CPT code, make sure you ask them about whatever E&M code that you've got too, because some of them will not pay no matter what for interesting things like your internet or website visits or consultations for this, that, and the other thing, even if it is doctor to doctor, and you have the documentation. Sometimes it's just easier just to bill the office visit. Yeah. You're working as a biller now. It's fun, isn't it? Always call your insurance reps. Email them, whatever you got to do. And just because you got their guidance on that CPT code last month doesn't mean it didn't change the next month. So those are also things. Don't make cheat sheets and think they're permanent. Things change all the time. So, yeah, it's fun. And this is your rationale for that one. It's crazy. Just when you're doing wordy ones, I mean, at least that gets you down to 50-50. you know you don't want to be a decision maker, and you know you don't want to interpret anything. Other than that, develop policies or provide advice after looking up payer specific. At least it gets you to a 50-50. That's a heck of a lot of help right there, for sure. Just taking keywords and not reading whole sentences. Must, always, never, those key terms on those wordy ones are helpful. All right, we got a patient in the emergency room who overdosed on heroin, and it was an accident. So, are we going to code? We're probably not going to code. We need to code to specific, right? Specificity, whatever I'm trying to say. My mouth is not going to say it today. So you know if it's a difference between 7 codes or 4 or 5, you know A and B are going to be out, right, guys? It's going to be a difference between your 1 and 2. Know that pattern, that if it's a difference between certain diagnosis codes, your answer is always going to be to the most specificity that needs to be. Y'all know what I'm trying to say. I got way too many vowels in there. I know. In different groups of different payers of different, oh my God. We could have Blue Shield, Blue Cross for Coca-Cola Company, and then we could have Blue Cross, Blue Shield for Best Buy employees, but they have 2 different group numbers, which both those group numbers pay differently on 2 different plans. It's a nightmare. Oh, I hate billing. Okay. So all you need to know is your differences between your 1 and 2. We know our 5, I think, is usually when the doctor accidentally gives them a reaction. It's an adverse reaction, something like that, usually. But 1 and 2. You don't want to know. Oh no. What did I miss on Tammy? What did she? They have different policies for each code, each insurance company. Yes, they do. Absolutely, Tammy. It's all based on different contracts. She's like, I don't want to know. You don't have to know it. Usually coders don't have to know all that billing stuff, so that's okay. Go into risk adjustment and you'll be just fine. Get your CPC, get on with Optum, work from them for a year from home, learning risk adjustment with them. And after your year, you can go work anywhere remotely from home. Doesn't matter. But that's just with the CPCA. They are hiring always. So don't worry, and they'll train you. It's rough, Tammy. All right, so we're saying C's across the board, everybody? Yep, C is right. That is unintentional. Very good. That's my last one. I'm going to go back up to the ones that Miss Edwards already saw this morning so that she can go get some rest. And I will see you at 7 o'clock in the morning and we'll get started again, okay? All right. And I'll have new questions for you, and they will be CPT codes because I've forced you to do anatomy all morning long. Hey, Sybil, and Catherine. Thank you for the share. It's my favorite name. Go get some rest. I'll see you in the morning. Very good, Terry. Which of the following regions of the neck? Cephalic is where, guys? Where's the cephalic? My granny was named Kathleen. Oh my. Where is cephalic? I'm just asking in general. Where's cephalic? Do you want in? Well, come on. Oh, you got a toy? My cat was wanting to play fetch. She was yelling at the door. Yep, we've got a vein in our head and neck that is cephalic. Cranial is also the head, and then facial is still part of our face, but a region is either cervical, lumbar, thoracic, or sacral. Do I have them all? I think I got them all. One. Yeah, those are regions. Very good, guys. Very good. Very good. Very good. All right. Chapter 19 includes diseases in which category? Travis, did you eat? James, did you eat? Dude, go eat. Everybody's getting C. This is A. This is B. This is C. And this is D. Chapter 19 has nothing to do with morbidity. Be careful on that one. If you go look at chapter 20, it has morbidity in it. Chapter 19 has no morbidity in it. The answer is D on that one. Because these are the ones that can be used as primary diagnosis codes. This is chapter 20. And chapter 20, because it is the cause of your morbidity, cannot be used as primary diagnosis codes. I did. Although I didn't write this question. This is a question from my CEU training for the month of May for 2022. So it's a new question for 2022. I did not get you too mean, did I? I did. Oh my gosh. Oh, my heart's having palpitations right now. So, it's the little things that will get you. All they did was add 3 little words, and you may have read all this injury and poisoning and took that and ran with it. Make sure the last words in the sentence still mean what you want it to mean. You're giving me chest pain over here. Whew, mean. That never happens. That's fun. All right. Which one is true about arthritis? Everybody's chicken now to answer the question, huh? Which one's true? What is AAPC's favorite answer? Yes, D is the correct answer. Good job, Twinkle. And there's your rationale with it. All right, which of the following statements about OA is not true? Number one, what is OA? Does anybody know what OA means? Jerry, the Saint Bernard is here. That's awesome. Awesome, awesome, awesome. That's very good. If you don't have that, go to your skeleton, your musculoskeleton guy, page 131 of your CPT book. It's the first page in musculoskeletal section if you're in the 2022 book. And write down the abbreviation of OA and then write out osteoarthritis. Very good, guys. All right. So which one's true? Not true. Not true. I hate these. You got to go find a wrong answer. Those are the hardest questions to do, is when they want you to find a wrong answer. I like finding right answers. Overuse of joints causes osteoarthritis. The one that is not true is the immune system. Yeah, y'all are right on it. And we got some rationale to go with that. For sure. Okay, documentation of a diagnostic scope. Must include which of the following? In this one, I had to go to our respiratory section. Yeah. We can go to our little guy on page 218. And it is not their favorite answer. They have tricked you on this one, actually. One 1% of the time, it might not be all of the above, but heck of a lot of times it will be. 99% of the time it will be, for sure. Thank you for all the shares. Almost have 2,000 likes. So where is this? What are we doing here? Everybody and their brother's been to the urgent care or something, or had laryngitis at one time in their life, right? If you break it down like that, laryngitis is laryngitis in your sinuses or nasal passages, or would it be somewhere else that we have no idea what this means? So maybe that would help. You know, if you think about it that way, laryngitis in my sinuses, that's usually nasal. Well, no, it's usually not in my nasal area, right? So we could get rid of those if we happen to know that it's not all of the above. But yeah, it is B. And so what this thing is, you remember we had a question earlier today about the stricter, the EOE, where we did the definition of that, EOE. So The thing that causes EOE, the stricture in the throat for the elderly patient, is this little thing that stops working to keep food and stuff down. And that is called this, whatever this is, however the heck you say that. And they gave it some stupid name named sinuses because the word sinuses means pear-shaped. So it's not that this is in your nose, it's just a pear-shaped crappy thing in your throat that stops working over time. So what I did, anyway, long story, on 219, I went in and drew in that, which is right above the larynx. It's those two little things that are on either side that are not labeled here. And yeah, my notes have all this stuff labeled too for you if you need it. But that's where I wrote this, so I would know it was in the larynx next time I saw it for the exam. So when you don't know, just kind of start thinking about your prefixes, your suffixes. Think about what you naturally know about the prefix. Larynx means throat. We've all had throat issues, couldn't talk, something like that. We know it's not in our nose, so that kind of can lead you to either not all of the above, which wouldn't be right because you know it's not in your nose. So hopefully that could help you get the right answer. It could be something you have no clue of. So anyway, there is the rationale for that one. I hope that's helpful. Helpful. Oh, this is a good one. Provider performs a nasal diagnostic endoscope on one side of the patient's nose. In documents, only one side was examined and includes the findings from that side, anatomic structures, things that were going on that one side. How would you code that? So are we going to use a 52 modifier, 53 modifier? We're going to do something with box 19. What are we doing? Thank you, Twinkle. Anybody got an idea? Where would you go to find the answer? What I would do is I would go to 31231 in my CPT book. 312. Three, one, two, 3, 1. And I would see 3, 1, 2, 3, 1. My code right here, my CPT code descriptor, says it is a nasal endoscope, diagnostic, unilateral, or bilateral, meaning in the code already, I can use the scope as unilateral and bilateral already, meaning my answer is when your CPT code descriptor says that a procedure is both unilateral and bilateral, you would never use the modifier 50 on that CPT code, or 52, or anything like that. 53? Nope. Nope, nope, nope. I got mean again. I can't believe it. I can't believe it. Yep, 52 says reduce services. We would not reduce it because the CPT code descriptor says exactly that it is unilateral and bilateral. So if we did our endoscope unilaterally, that's all we need to report with the 31231, that we would not do reduced services on it. We would not code it as a as a 53. 53 is discontinued procedure. We wouldn't do that either. All they said was that they documented doing it only unilaterally. It is a complete exam, though. That is a 100% complete exam. Just because it was done unilaterally doesn't mean it isn't complete. According to the CPT code descriptor, a unilateral procedure can be done with this CPT code, and it is a complete procedure. That's exactly what that means. When they tell you that you can do the procedure as unilateral or bilateral, that means that you can absolutely do it unilaterally, and it is a complete. Nope, you're wrong. That is a complete procedure. We would not use 52 just because they called it unilaterally, because our CPT code descriptor. Now, if our CPT code descriptor did not have that, it just said bilateral, then great, wonderful. Do the 52. But because our CPT code descriptor defines this procedure as unilateral and bilateral, or means and, remember, always, that both of those, either being done unilaterally or bilaterally, is a complete procedure. There is no reduced services on this one. Got it? All right. And there's your full rationale. Boys, I can hear them starting to argue. And this is our question. Y'all already know what the answer is because y'all have already done this one. Because I asked y'all what the definition was. What? What?
Where's that ring?
Why do you want to see the ring? Well, it's your ring.
Yeah,
anyway,
exactly.
But he can't have it anymore. And don't you put it on your damn finger either.
Why would I?
Yeah, the two fire departments and an ER with a machine like Dremel with the drill head. They could. That's all. They ruined diamond.
Let me just shove it on my finger forcefully. Yeah,
no,
let me just do that.
It's not for a finger. It goes on a necklace. It's supposed to go on a necklace.
Are you? When the ring won't go on the finger, why do you just push it on more?
He did.
Stupid.
He shh, don't call him that.
I didn't say he was. I said he was.
Yes, we know what the definition of that is now. And we've already done this one with the eosinophils. Okay, let me find you some more questions real quick. I got tons. Let me just pull them up real quick. Let's see. What do we want to do? Oh, we did anim. Well, you know, I had some lab and path questions the other day that people were asking me about. Right? Let's look at some lab and path, if that's all right with you guys. Make sure all these are not written all over and are formatted properly. Get our lab and path on. Oh, I don't even know what a qualitative FDP. James, if that's you again, no. Good gracious. Having to erase all this writing. Why do I write all over this stuff? But I do. All right. We've got our lovely .803s. .803. So we've got our drug screening. Adding the lesions. Yep. Adding how many we've got. We've got drug screening. So our 805 is just a dipstick with direct visual looking at it. Our 806 is dipstick, also with an instrument assisting us, and then 807 is all done by instruments. So we just need to figure out if we're just visually looking at things or not. So there's our question, and I run to my word dipstick and match that up. Obviously we're doing it, but are we going to read them, or is the machine going to? I do see visually read, positive, and then that's it. So I would definitely start out with just my 05. Would we do this particular CPT code times 2 ever? Would that ever happen? Usually those dipsticks have multiple drugs in them. You dip them in the urine and it'll do for meth and marijuana and all that stuff all together, like your pool chlorinator. So that would be unlikely that we do anything like that. So, yeah, that's how I would handle that question. All right. What are we keeping? What are we getting rid of here? I like getting rid of B for sure. What's our 88323? What is that? We're way back here. 88323. Consultation. 323 is slides. Our 25 is records. And our 29 is during surgery. This question was on Betty's and Wendy's exam in February. They took theirs in person. Yes, we are doing records. Absolutely. Good job. All right. My favorite codes. I like these codes. These are my favorites. 88304, which is like our simple removal, simple things, cyst, biopsies, gallbladder, that's underneath there. Our 05 is our disease processes like H. pylori, things like that. If we want to look for a disease, it's usually our 05. 07 is craniotomies. And then 09 is cancer resections. 07 also does resections, but they're usually not cancerous. So we'll just check out our question. And we got plaque. I know where that is. If we look through all of these, through 04 and 05, you'll find artery under both of 04 and 05, but 05 has biopsy where 04 has the plaque. So we know we're going to have 04 in our answer, right? So we can get rid of D. We can get rid of C. Now we just have to decide, is the plaque first or second? And since our plaque is tiny, and then our second specimen is a big old thing at 8 centimeters, we know that the 8 centimeter one is going to go first. Same thing like an integumentary or even an OB. When you're delivering twins and one of them comes out vaginally and the other one comes out C-section, you're going to do the bigger procedure first. C-section baby will be first, even if it was born second. Same thing in integumentary. You won't code a bigger code before you code the second smaller item code. So just knowing the size differences are super helpful. That this is our big mama jama. It'll go first. I don't care where it's at as long as my 04 is the second code And we only have one answer where my second code is the 04. So B is our answer. Does that make sense? You got to remember to code your bigger issue first. That's it. You're getting closer, getting good. Good job. Usually not a 99. This 25 is way out there. It's probably a difference between the 63 and the 62 because they're super close together. What is our 80162? 80162. Total. Oh, yeah. Mean knows this one. She's seen this one 1,000 times. Total digoxin. And our other one is some other type of digoxin. We do have an AFib patient. Doc orders, that's all you need to start looking up. Try not to look at the bottom all the way down. Don't really care. From the bottom up with totally helps. It's free. This one's free. And the other one is total. Just look for what the doctor ordered and move on. Super helpful. $78 and $79 are super close. $62 and $66 are okay. Yeah, let's go see. 585 or 85. Good gosh. 853. $78 and $79. We got a qualitative and a quant. Yep. That's where that FDP was. I'm like, what the heck is that? And we're doing quant. So that's Yep. 79. Yep. Very good, guys. That's all the questions I've got for y'all, unless y'all have any questions y'all want to ask. Anything at all? I know. It takes 5 minutes out of the 2 to just to find the dang codes. It does. You've really got to practice. I keep meaning to make this list of just randomized, hard to find CPT codes that per sections, just so you can go searching one day so that you could practice getting to the codes that are either out of sequence, not in sequence, new codes, or just unusual codes so that y'all can practice. I know, and not rip the pages. It's so hard. It is. And it'll be even worse that day that you're there on the exam too. You're very welcome, Bells. Yeah, it does seem to help. Looking at the top range of codes does help. Absolutely. Get you there a whole lot faster. I'm aggressive. Tammy's just throwing pages here or there. Yep. It's rough. And by the time, if you go from the beginning of the exam to the end of the exam, by the time you get to the back of the book, or the last questions, you'll be in the back of the CPT book and you're exhausted and tired, and then you got to go find all these out of code or out of sequence exams. That's why sometimes it's just better to start at the back of your exam and work your way forward, because you know more about where the E&M codes are and stuff like that in the front of your book, hopefully. And there's not so many that are out of sequence. There's still some, but it's not as much as lab and path. So if you start out with the convoluted things that are always out of sequence, you won't be so give up tired by the end of 3 hours, 4 hours, where you're at. Sometimes that strategy works well for people. And forget. I would start from the back and forget and start bubbling your bubbles like you were in the front of the book. Yeah. Take index cards to hide the questions so you can go straight to the answers first. Take you a ruler so that you can line up your answer sheets with your bubble sheets. The advantage of being online is that your question and bubbles are all on the same page. That's wonderful. But during your in-person exam, be sure and take a ruler with you so you can stay on the right bubble for the right question. Laughing at Tammy. Oh gosh, y'all, I'm just tired. It's been a day. I'm aggressive. I love that one too. Take some index cards, 2 of them, so that you have one to cover up your question, and then one that when your answers have multiple codes in them and you're freaking out about all the modifiers or things to look at, you can cover up your question, but you can cover up your answers so that you can just go one number at a time. See what your differences are. What would make a big, huge difference here in helping out, picking out the right codes so that you're not looking at all the other stuff later on. Take it one code at a time. Now we can see what's similar. We know that B and D are similar. The other 2 are out of sequence. Oops, if I could do this. So we can do it that way a lot easier. Then we just need to know the modifier's the same. The only difference is the 32 and the 07. You don't have to worry about anything else. And we're doing craniotomy, and everybody knows craniotomy is Jen's favorite code. We know it's an 07. Pick that 07 and mosey on to your next question and don't read none of the rest. Right? Yep. Did you say there was a vocabulary on sale?